first scientific session of second day of first National NCD Conference, Bangladesh. This session will be chaired by Dr. Alia Nahid, Scientist and Head Initiative for NCD ICD Derby. The chief guest of the session is Dr. Mahfuzur Rahman, Country Director, Pure Earth, Bangladesh. And me, Dr. Mithila Farooq, Head of the Department NCD, Bangladesh University of Health Sciences, will be the moderator of this session. In this session, we will have one international speaker, one national speaker, and 4 other speakers. Now, I would like to request the chair of the session, Dr. Alia Nahid, and the chief guest, Dr. Mahfuzur Rahman, to please come up on the dais and take their seats. Now, I would like to request the speakers of the session, Professor Dr. Nazrul Islam, Sanjida Binte Ali, Bilkis Banu, Nabila Aftabi Binte Islam, and Khandokar Fatima to please come up on the stage and take their seats, please. Now, I'd like to request the session chair, Dr. Alia Nahid, Scientist and Head Initiative for NCD ICD Derby, to give the welcome speech of the session, please.
Thank you, Dr. Mithila Farooq. It is a great privilege to chair this important scientific session today. So I welcome all the audience in this hall and our respected audience connected through Zoom for supporting us this program. So this program will run for 90 minutes. In this limited time, we will be listening to 4 speakers who have come up with brilliant ideas of their research and present their results before us today. So we will be highly encouraging our guests, audience, and also the panelists to try to understand the gaps in their research or their strengths and have a vibrant discussion in the audience, because these sessions are also meant for giving them feedback, and it is a learning curve for all of us. Without further ado, I would like to request a moderator to run the session. So over to Mithila. Thank you.
Thank you, Dr. Aliappa. The national speaker of the session, Professor Dr. Nazrul Islam, Professor, Department of Rheumatology, BSMMU. He will speak on prevalence of osteoporosis and associated factors in patients attending a rheumatology clinic study from a developing country. I would like to request Professor Dr. Nazrul Islam to please start his speech.
Bismillahirrahmanirrahim. Good morning, ladies and gentlemen. It's my privilege to thank the organizer in this August gathering to giving me the opportunity to highlight a different aspect of the NCD, not been talking as the important aspect. This is a musculoskeletal disorder. I would like to share you with a little aspect or a single aspect from our study. Of course, not a epidemiological study, but in a tertiary setting information. I hope it will enlighten the information. This information will enlighten the NCD thinking people in the master plan. So with this, we know the osteoporosis is one of the burning issue, emerging issue, emerged issue, an issue of the globe, both the developed and the developing country. And according to the IOF estimates, 1 out of 3 female and 1 out of 5 male above the age of 50 years suffer from osteoporosis. Right now, in a whole over the world, about 200 million women suffering from osteoporosis. In Europe, the osteoporotic disability is more than cancer, but we are talking about the cancer more than that of the osteoporosis. In Asia, if you look at that, prevalence of osteoporosis in India among women above 50 years of age, it's the 20%. In China, it is around 50%. In Japan, if they consider the lumbar spine, it is 35%. In hip, it is around 10%. And global estimates from IOF again estimated that 50% of all hip fracture will occur in Asia by 2050. And of course, everybody will agree with me, it's a greatly underdiagnosed and undertreated condition. We are growing, our country is growing, population is growing. Now we do have around the 18 million people, and interestingly, this is going to change the population pyramid of Bangladesh. If we look to the nearby country China, the population pyramid is becoming reverse. Our population above 50 years also increasing, and it will increase in the course of our life. Life expectancy of both of our people are increasing. Around 74% female are surviving, and male are about 72 years. So it says us we are heading to some age-related disorders. Osteoporosis is one of them. We have calculated from the 2011 census, about 14% of the subject in our country above the age of 50 years. And from IOP estimates, we have calculated around 6 million male and female are now suffering from osteoporosis. You know, about the diabetes, that is 7 or 7.5 million something. Based on all of this information, we made objectives to determine the prevalence of osteoporosis among rheumatic patients, to evaluate the associated factors among of them. 267 consecutive patients of both gender above 50 years of age were enrolled during the period of 2015 to 2018. And there, with them, we have evaluated them clinically and by some laboratory tests. We did calculate the FRAX score and also did the DEXA scan at lumbar spine, hips, and the wrist. The WHO definition of osteoporosis we have followed to define the cases. Osteoporosis is less than minus 2.5 T-score. Severe osteoporosis less than 2.5 and associated with the 1 fragility fracture. FRAX score, there we have taken for major osteoporotic fracture value more than 20% and for the hip more than 3%. Now, if we look at the results, I believe these results will enlighten the other researchers to think about their future research. The age category in this year we have seen 60 to 69 years ages are higher, that is about 54%. And urban people are more than the rural one. Still, our senior people are little lag or behind in education. Primary education rate was 56%. Housewives are the one important occupation, and they are about 88.4% in our observation. Normal BMI and overweight and obese were respectively 27% and the 65%. And still in our country we are seeing many of our subjects failing to notice the parental history of fragility fracture, as because in the terms of osteoporosis, we consider as a risk factor. Some of the vague complaint is associated with the osteoporosis, and one of this is the unexplained low back pain, and it's about 56% cases in our study. Self-reported height loss is another clinical marker for the suspicion of osteoporosis. It is about in the 50% of the cases. History of previous fracture were also there, but tobacco consumption is still among the female around 57%. Disease diagnosis especially, and taking the history of steroid, everybody the misuse of steroid is our country's ongoing, and here the percentage is about 10%. And both the rheumatoid diagnosis and the secondary osteoporosis are also in a good number of cases. This information will enlighten us about the age of the female in our country. When we did the study, the mean age of menopause was 47 years, and duration of menopause and to our visit during the enrollment, it is about 17 years. And we do have about 87% subject as the natural menopause. Of course, a little good percentage also with the surgical menopause, and that is not less, it is about 13%. Insufficient vitamin D we have noticed in this study, and that is we observed in about 74.3% of the cases. And while managing this type of cases, creatinine is one of the important factor. 1/5 of the subjects are suffering from with the high creatinine level. The striking part of this one, the prevalence of osteoporosis at spine, hips, and the wrist. In this study, the prevalence of osteoporosis in lumbar spine is the 38%, hips about 17%, and the wrist 65%. In a resource constrained setting, FRAX is an important tool for the physician and also the researchers. With that, we can estimate the possibility of or probability of 10 years risk of major osteoporotic fracture and the hip fracture. So in our study, the major osteoporotic fracture risk was 3.7% and without BMD. When we have included the BMD report, so it gone up to 4.1%. But FRAX rates hip risk best and better than the major osteoporotic fracture. At hip, without BMD, it is 33.3%, and with BMD, it goes down 25.5%. So it will be evident or helpful for the scientist, as because if we look at to the osteopenia, so this again very high. It is osteopenia with BMD, in the lumbar spine is 42%, it is in the hip 58.8%, and wrist it is 26.6%. So the FRAX going to help us if anyone want to do a research on this. We make an interest of seeing what happens with the only, if we analyze the only with the postmenopausal women. In our study, 249 female were postmenopaused. Among of them, the prevalence of osteoporosis and osteopenia is near similar to that of the other observation, but striking one with the 10-year probability of fracture that has been gone up, and wrist is again gone up. In wrist, the prevalence of osteoporosis is 82.7%. Why to mention this one? IOF, NOF, once upon a time, didn't included the wrist T value to diagnose the case as osteoporosis. But once then there are several reported came up, and I also presented this one in one osteoporosis conference, and subsequently it turned out is that many of the cases of osteoporosis we miss if we don't analyze the wrist value. So among the post-menopausal women, the wrist is a good marker to determine the osteoporosis among of them. We have to look at the risks of osteoporosis among of them. Bivariate analysis says many of the factors are related with the risk of osteoporosis, starting from the woman gender, urban inhabitant, low education level, housewife as a profession, normal BMD, and the FRAX score of hip with BMD. But once we done the logistic regression, only BMI and the FRAX score of hip was turned out as a independent risk factor of osteoporosis. So at conclusion, I'd like to mention you, both osteoporosis and osteopenia are prevalent among rheumatic patients above 50 years of age. Prevalence of osteoporosis is high with wrist followed by vertebra. Vitamin D deficiency is a frequent observation. 1/5 of the subjects had high serum creatine level. BMI and the FRAX score of hip with BMD were independent risk factor of osteoporosis from our study. I would like to acknowledge my colleagues and Dr. Asif Khan, Dr. Fahid bin Nozrul, Dr. Nira Firdaus, Dr. Najia Anjum, Masum Billah, Professor Hans J. Jeraskar, and Dr. Nandita Debnath, Mr. Kamrut Jaman, and all of my beloved patients participated in this study. This study was funded by the BSMMO. And with this, thanks a lot for your patience hearing. Thank you very much.
Thank you, sir, Professor Dr. Nazrul Islam. By this time, our international speaker, Dr. Kingsley Agho, has joined with us on the virtual platform. Welcome to the scientific session of First National NCD Conference. And now I would like to request Dr. Kingsley Agho, the Associate Professor, School of Health Science, Western Sydney University, to please deliver his presentation. And he will speak on the status of non-communicable diseases surveillance in Nigeria. Dr. Kingsley Agho, please.
Thanks for the introduction. My apologies for running late. I was in the wrong Zoom platform. In my today's topic, I want to talk about the status of non-communicable diseases surveillance in Nigeria. For the benefit of those in the audience who is not quite familiar with Nigeria, Nigeria has one of the highest population in West Africa, of about 206 million. As you may know, Africa is divided into three sections. We have the Anglophone, that means the English-speaking Africa, the Francophone, the French-speaking Africa, and the Arabophone, the Arab-speaking Africa. Nigeria has got borders with a lot of countries like Ghana, Cameroon, Chad, and the ratio of men to women is 51 to 49%. The Nigeria health system is divided into three tiers. We have the tertiary, we have the secondary, and we have the primary. The tertiary is under the federal government, the secondary is under the state government, and the primary is under the local government. So I just felt I should give an overview about Nigeria. Non-communicable diseases continue to be the cause of mortality and mobility worldwide, including Nigeria and other countries, even Bangladesh. In Nigeria, it was estimated that an average of 29% of all deaths are related to non-communicable diseases, and 29 premature deaths are among this age 30 to 70 years of age. One of the reasons for this, as I've indicated, one of the reasons for this high increase of non-communicable disease in Nigeria is more to do with urbanization, industrialization. That means urban-rural migration. And as we've already said, just like in other countries, there's an equitable distribution of non-communicable health delivery services. In Nigeria, especially the primary health care, which is at the local government level. And there's also a cultural belief, which, most Africans believe, disease don't kill black man. That means, black man don't die of disease. Some of this cultural disease has been a problem with a non-communicable surveillance in Nigeria. Now, these are some of the data. Now, these data are quite old. And as you can see, the first graph is the prevalence of common cancer in female. And one of the highest leading cancer, non-communicable disease in female is breast cancer. Then in the bottom graph is prostate among men. One of the key message I want to say here is that some of these data are old because of lack of surveillance in the country. So I want to go on to talk about more. Now, this is another graph that look at the selected adult risk factors, which is, like obesity, blood pressure, alcohol consumption, and tobacco smoking. Some of this information that I'm presenting here, some of them are almost a decade ago. So this is one of the problems we have with non-communicable surveillance disease surveillance system in Nigeria. One, the data is too old, so the information we are giving is biased. And secondly, there's no routine data collection because of some political reasons. And thirdly, lack of awareness of Nigerians or the knowledge of non-communicable diseases. Like what I said previously in my introduction, people believe, especially those who are not educated, believe that, disease doesn't kill black man. And the third one is inadequate routine medical checkup. People don't go to medical checkup. People still believe in taking traditional medicine or drinking traditional herbs. They think that is much better than the Western medicine. Now, what is the objective? The objective of this presentation is to examine the status of the non-communicable disease surveillance in Nigeria. To do this, I did a systematic review. The aim of this systematic review is to look at first the tools, the monitoring framework, and the gap, and also recommend for future interventions. So, in my systematic review, I look at studies that was between January 2010 and 2022, and all articles published in English, not peer-reviewed articles, as well as gray literature, which is government reports. So I used, in my search strategy, I look at these 4 themes: not communicable diseases, surveillance, policy, which included guidelines, standard and framework, and as well as Nigeria. I use 5 databases to do my search. I use the Google Scholar, the Embase, and so on and so forth, I also search for gray literature. A lot of publication on not communicable disease in Nigeria is based on gray literature. Then this is how I did my search. I found this 16,652 article. When I remove duplicates, I have 17,167 as indicated in this table. Overall, and I have 10 studies met my inclusion criteria, and which I review for this presentation. Now, so what are my results? Overall, the summary of my result is that is 1 to do with the monitoring of risk exposure or risk factor. 2, the monitoring of the outcome variable, which is not communicable diseases. There are a lot of them, and the health system capacity and ability to respond to people who have severe not communicable diseases. And the last thing is inadequate knowledge of not communicable diseases to Nigerians or to the population. My recommendation, or based on my search, I found that there's no guideline or protocol standard for the management of major non-communicable diseases. 2, no national population-based cancer registry. As we have in Australia, there's a cancer registry, but in Nigeria, there's no cancer registry. The 3rd is there's no operational policy, strategy, and action plan to reduce the burden of tobacco use. People still smoke. People think smoking is part of, reducing stress and things like that. And additionally, there's no policy, strategy, and action to promote physical activities. Like other countries, if you are skinny and slim, they think you have diseases. Everybody wants to be a bit, big. So there is no issue around physical activities. Everybody wants to own a car. Everybody wants to have an air-conditioner car. Nobody wants to walk. So there's no policy around this. And this is one of the reasons why communicable disease is on increase. And there's no operational policy and action to reduce harmful use of alcohol. People in Nigeria or in most developing countries think alcohol is a way to distress. That if I take alcohol, it enables me to distress. And additionally, there's no policy as well to a plan for mental health. Mental health is being seen as a stigma. Even in Nigeria, when people have mental health, they take them to the villages because they think it's a stigma to the family. So there's no policy in place to deal with this. And there's no international policy to reduce overall non-communicable diseases. So this is some of the conclusions I found when I did my systematic review. Now, what are the way forward? There are 3 things: at the individual level, at the community level, and at the government level. Because interventions to improve non-communicable disease is going to be cut across the 3 levels. At the individual level, there's room for routine medical checkup. And this can be done through television ad, as well as, try to engage, the community in this kind of approach. At the community level, misconception by the community that the harmful. Like, for example, like I did say before, people think, disease doesn't kill black man. So it's an idea people have, but that's not true. So we need the community to be involved to change this kind of perception. And at the government level, there is need to do e-surveillance. E-surveillance will be needed in order to monitor the general public health outbreak and to improve data collection. Thank you very much. And I look forward to your questions.
Thank you, Dr. Kingsley Agho, for your presentation. Sanjida Binte Ali, I'm requesting you to come.
Assalamu alaikum. Good morning, everyone. Honorable Chair, respected Chief Guest, and all present guests and colleagues. I would like to present the study titled Pattern of Antihypertensive and Antidiabetic Drug Use and Treatment Cost in Diabetic and Hypertensive Patients in Bangladesh, a cross-sectional study. Introduction. The burden of hypertension and diabetes is increasing globally. In Bangladesh, the prevalence of hypertension and diabetes notably increased in female and male who were 35 or more than 35 years old. Between 2011 and 2018, the prevalence of hypertension increased in female from 32% to 45% and in male, it increased from 20% to 34%. In case of diabetes, in female, it increased from 12 to 14%, and in the male, it increased from 11 to 14%. We know that pharmacological treatment can manage the hypertension and diabetes. However, treatment adherence depends a lot on out-of-pocket expenditure. In Bangladesh, the average annual cost per patient for type 2 diabetes is more than 860 USD. The incidence of catastrophic expenditure for diabetes is 1.4% and for hypertension 1.3%. So why we did this study? Because the data on hypertensive and anti-diabetic drug and treatment costs are limited in Bangladesh. Therefore, we identified the common pattern of using antihypertensive and anti-diabetic drugs among the patients in Bangladesh. And also, we estimated treatment cost of hypertension and diabetes. Methodology. We used cross-sectional study design to conduct the study in 8 divisions in Bangladesh. Our study setting was community setting, which is within a 5-kilometer radius of one public and one private facilities in 3 facility tiers in Bangladesh. Our study population was hypertensive and diabetic patients in the community who were 40 or more than 40 years old. We collected that data between August 2019 to January 2020. We recruited 354 participants for this study. Participant recruitment procedure where we considered a catchment area within 5 kilometers radius of a respected facility. Then we created an inventory of individuals with hypertension and diabetes through door-to-door visit at home. Then we randomly selected the participants from the sampling list, and then we conducted quantitative survey among 354 participants. From the study, we found that the average age of the participant was 52 years and 70% of the participants were female. In case of education level, we found 1 out of 4 participants never went to school and 1 out of 3 participants completed secondary education. In case of morbidity status of the participants, we found that 53% participants have hypertension and 1 out of 4 participants had both conditions, hypertension and diabetes. Here we can see the health-seeking pattern of hypertensive and diabetic patients. Among the hypertensive patients, 57% sought care from private facility, and among the diabetic patient, 71% sought care from private facility. Pattern of using antihypertensive and antidiabetic drugs, we found 58 antihypertensive and 45 different antidiabetic medicine were reported to be consumed by the patients. In case of antihypertensive drug, beta blockers and angiotensin receptor blockers are the two most commonly used drug group. And whereas in case of antidiabetic drug, we found sulfonylureas and biguanides are the most commonly used drug group. In case of hypertensive patients, they usually go to public facilities and spend $7, and when they visit private facilities, they spend $11. Whereas the diabetic patients, they spend in public facilities $6 and private facilities $20. And patients who have both condition, hypertension and diabetes, they spend $15 in public facilities and $30 when they visit in private facilities. Cost of treatment included ticket fee of facilities, doctor's visit fee, medicine cost, cost of special food, test and diagnostic. We concluded here that types of medicines used to hypertensive and diabetic patients in the community is diverse. Diabetic patients more frequently seek care from a private facility than that of hypertensive patients. Overall, cost of treatment is higher for diabetes than hypertension. Introducing a generic treatment protocol for hypertension and diabetic care could reduce the out-of-pocket cost of treatment for hypertension and diabetes.
Thank you, Sanjida Binte Ali, for your nice presentation of your research findings. Now we will move on the next presenter, Bilkis Banu, Associate Professor, Department of Public Health, Northern University of Bangladesh. And her title is Comparative Effect of Traditional versus Communication Technology-Based Health Educational Intervention Focusing on Diabetes in Bangladesh, a randomized control trial. Bilkis Banu, please.
Respected Chair and Co-Chair, honorable speakers from home and abroad, and my dear learned audience, Assalamu alaikum, and a very good morning to all of you. Still we are in morning, yes. So welcome you all to the very time-demanding and burning topic, that is effect of traditional versus communication technology-based health educational intervention focusing on diabetes in Bangladesh, a randomized control trial. Diabetes is a huge and growing problem. Globally, the prevalence of diabetes and its increasing cost, and I am mentioning here its related cost due to complications, both are increasing not only in the world, but also all over in our country, Bangladesh. So from morning session due to now, we are hearing this issue that yes, prevalence is increasing, we are now in risk. So, and most important issue, the cost is increasing. So I'm not uttering here again the numbers and here the statistics. So what can be done in this situation? For healthy people, diabetes can be prevented, and for diabetic patient, it can be managed through 7 self-management components. These are drug, diet, physical exercise, follow-up visit, avoid tobacco, blood glucose test, and food care. We know that to actually improve the adherence of diabetic patients in these 7 self-management components, there are so many types of health educational intervention is existing in the world and also in Bangladesh. Amongst them, these are 2 I am mentioning. One is communication technology-based health education, that is CTHE, hereinafter I will refer. Through CTHE, actually the health educational intervention is covering through voice call service or SMS. And another, which we are seeing last 5 to 7 decades, that is traditional health education. Hereinafter, I will refer it THE. This type of health education, we are already successful in our vaccination program and so many, which we are conducting through household visit with our health assistant. But the question is, which one is effective to improve the adherence of diabetic patients' self-management? This was the question of our study. In line of this, we planned this study to compare the effectiveness of these 2 types of intervention. It was a randomized control trial and conducted over a period of 18 months, and we conducted it in Thakurgar Shastro Seva Hospital among 990 adult diabetic subjects. Actually, in this study, we had 3 different groups. The first group was CTHE group, that is Communication Technology-Based Health Education group. The second group was Traditional Health Education group, and third one is the control. So we considered 330 diabetic patients for each group. We used pre-tested and semi-structured questionnaire by face-to-face interview method, and anthropometric clinical status we measured by tools, and blood glucose level we actually collected it from Diabetic Patients Guidebook. We all know in Bangladesh, under Diabetic Association of Bangladesh, all registered patients had the Diabetic Guidebook, and we are collecting the clinical information from there. Now I am dragging you to the study process. I already mentioned that we had 3 groups, CTHE, THE, and control group. So we used same questionnaire from pre-intervention data collection and post-intervention data collection. During the intervention period in the first month, we actually provided one-day educational session by using a colorful and pictorial educational material to all groups. Afterwards, for the CTHE group, we gave them reminder and monitoring-based health education through voice calling. For the THE group, we conducted reminder and monitoring by health assistant through household visit. And for the control group, we didn't conduct any reminder and monitoring. And finally, we collected the post-intervention data. We actually used the data as statistical software and techniques. We used frequency, mean SD, analysis of covariance, logistic regression, and we also considered some measuring definition as the adherence of self-management components of diabetes. Now come to the main point, the answer of the question, which one was effective for this improving the adherence. At first, we saw that there was no significant association between the groups as the background characteristics of the study subjects. Afterwards, for the change in knowledge, we found by the ANCOVA-Bonferroni post-hoc comparison test, most of the components under knowledge. We found, you can see here, the blue highlighted part, that most of the components had improved knowledge amongst the CTHE group in compared to the THE group. So here, CTHE group was prominent. In case of adherence, change in adherence, for the drug adherence, we found CTHE group was more prominent than the THE group. But the alternate scenario we found for the dietary adherence, there we found actually THE group prominent. But for the physical exercise and follow-up visit or blood glucose test, we found again CTHE group was prominent in compared to the THE. Then for the avoid tobacco, we again found CTHE group prominent compared to the THE, but foot care was prominent for the THE group here in the level of adherence improvement. So likewise, change in knowledge, we actually also found change in adherence. Most of the component of adherence also improved in the adherence part for the improvement for their improvement in the CTHE group actually. So in the same line, we found CTHE group was more prominent compared to the THE in case of health outcome, as well as most importantly, CTHE group was cost effective compared to the THE group, because for the THE group, actually health assistant need to go to home, whereas CTHE group, we only can do the phone call. So it is cost effective. So in conclusion, I want to say that CTHE-based intervention with reminder and monitoring seems to be more effective compared to the THE-based intervention in improving knowledge, management adherence, health outcome, and intervention cost of peripheral diabetic patient of Bangladesh. So I want to recommend to replicate similar type of intervention for chronic disease, to design similar conceptualized mobile phone application for global diabetic patient, to plan multi-leveled and comprehensive studies in future. In line of the recommendation number 2, we actually developed the smartphone application based on these 7 self-management components. So with this smartphone application, to introduce it in the Google Play Store, we already did the perception study. Now we are looking for the support to conduct the effectiveness regarding smartphone application. If anybody have interest, please contact with us. And finally, I want to convey my thanks to the organizing committee, because the NCD Congress 2 years back, hopefully, I already shared my baseline information in that conference, and I was very fortunate that I received Best Presenter Award over there. So thanks to organizer committee once again, so that I'm sharing my intervention outcome here, and hopefully upcoming any city conference, I can present my perception study over there. So it's a long way of continuing these NCD studies, actually diabetes studies with me. Thanks to all of you.
Thank you, Bilkis Banu, for her research findings presentation. It was really interesting. And now we would like to move on the next presenter, Navira Aftabi Binte Islam from Marks Medical College, Dhaka, and she will speak on food consumption in an English medium school children during COVID-19. Navira Aftabi, please.
Respected Chair and dear audience, Assalamu alaikum. I am Dr. Navira Aftabi bint Islam, Assistant Professor, Dental Public Health Department, Marks Medical College, Dental Unit. My title is Children's Food Consumption Habit During COVID-19 Lockdown. The term of coronavirus disease 2019 is a contagious disease. The disease has since spread all over the world, leading to an ongoing pandemic. By WHO, the first known infectious SARS-CoV-2 are discovered in Wuhan, China in 31st December 2019. The first 3 known cases of COVID-19 were reported on 8th March 2020 by Bangladesh Epidemiology Institute. First fully lockdown declared by the Bangladeshi government from 23rd March to 30 May 2020. Children were most vulnerable at this situation. They couldn't go to outside to play, and the school class was online basis. So they were upset mentally and physically. Eating of variety food was one of the recreation for them. It has led the children into a sedentary lifestyle and physical inactivity, which may increase the incidence of obesity. Objectives of the study: to assess children's food consumption habit during COVID-19 lockdown. Materials and method. The study design is the cross-sectional study population, caregivers of 8 to 11 years of English medium school students in Dhaka city, Bangladesh. Sampling method, total 130 caregivers of 223 children were selected purposively. Data collection instrument, online questionnaire were developed and delivered to the caregiver of the children's. Study period, 1st to 31st October 2020. Inclusion criteria, 8 to 11 years children of a renowned English medium school in Dhaka city and their caregivers. Exclusion criteria, other respondents, data management and analysis, SPSS version 23. Research ethics, this research was only based on online questionnaire administration. It had no clinical examination or physiological or laboratory testing. Informed consent, consent was taken by the respondent's caregiver. And this is the result. Female respondent was 70% and male was 30%. And age distribution of the children, 8 to 9 years age children was 24%, 9 to 10 years 35%, 10 to 11 years 41%. Educational qualification of the caregivers of the children, 10 to 8% was HSC, 76.2% did their graduation, and 13.1 was master's and above degree. Monthly family income of the children's parents, 11.5% family income has more than 1 lakh, 66.2% more than 2 lakhs, and 22.3% family income was 3 lakhs and above. Daily cooking at the home, 22.3% respondent answered that they cooked food by their own, 77.7% cooked food with help of the maid. And this is the daily physical activity of the caregiver. 22.3% caregiver answered that they do physical activity always. 29.2% answer they didn't, and 48.5% answer sometimes. Workplace of the caregivers, among 130 caregivers, only 20% was work at home, and there are more 93% was homemaker. And this is the 7 days food frequency of the children. Here, milk and milk product, chocolate and chocolate product, and all types of fast food children intake frequently. This is the extra food intake frequency of the children per day. 30% take extra food 1 times, 60% 2 times, 10% frequently. Extra food made or ordered by 6.9% homemade, 43.1% online ordered, and 50% answer both. And this is the frequency of online ordered food. 43.1% ordered online food 1 to 2 times per week, 44.6% ordered 2 to 3 times per week, 12.3% ordered frequently. And this is the ordered food type. That was 66.2% ordered fast food, 22.3% ordered lunch, and 11.5% ordered dinner. Body shape change of the children by their parents' perspective at this lockdown period. 63.1% parents said that they thought their child gained overweight. 36.2% thought no change, and 0.88 that was missing. And this is the association. There is a significant association between frequent online food order and the change body shape of the children. The p-value is 0.04. And there is also another association between monthly family income and how many times children intake extra food in a day. The p-value is 0.01. Why it is important? People of our country who possess financial capacity teach their children in English medium school. Most English medium children in our country are not doing any household work. Most of their mother is homemaker or enough facility with maid. But for now, in this lockdown, it's very important to do such type of work by themselves, like their own work should be done by them, like they can arrange their bed, reading tables, dresses, involve in household work like sweep the floor, clean furniture, do physical activities with their parents, home gardening, etc. Conclusion. It goes without debate that most children tend to be fun-loving, but due to the lack of outside recreation activity and social distancing, they are becoming prone to eating and taking unhealthy snacks. Encourage them to take healthy food and do regular physical activity is most important to overcome this situation. Limitation. Respondent of the study was too small in number and respondent could conceal the data. Thank you.
Thank you, Navira Aftabi Binte Islam, for your research findings presentation. Now, we would like to move on the next presenter and the last presenter of this session, Khandokar Fatima from Department of Public Health and Informatics, BSMMU. And her presentation title is Transcultural Adaptation of Bengali Version of the International Physical Activity Questionnaire, short form, among healthy adult population of Bangladesh.
Myself, Dr. Khandokar Fatima, MPH student in Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. My study title is Transcultural Adaptation of Bengali Version of the International Physical Activity Questionnaire, short form, among healthy adult population of Bangladesh. Physical inactivity is a risk factor for premature mortality and several non-communicable diseases, a topic of global discussion. Globally, 7.2% and 7.6% of all cause and cardiovascular disease deaths respectively are attributable to physical inactivity. A sedentary lifestyle causes 5.3 million deaths worldwide each year. The existing data suggests that physical inactivity is already a global public health problem and increasing rapidly in developing countries. Recent estimates indicate that the worldwide prevalence of physical inactivity in adults is 31%. The purpose of this study is to explore the test-retest reliability and validity of the Bengali version of the IPAC short-form questionnaire in a population-based sample of healthy individuals in Bangladesh. The specific objective is to translate the English version of the IPAC short form in Bengali, to examine the validity of the translated Bengali version of the IPAC short form, to determine reliability of Bengali version of the IPAC short form, and to evaluate psychometric properties of Bengali version of the IPAC short form in Bangladeshi context. This was a cross-sectional online-based study which was started from the 1st November of 20th December 2021. Approximately 100 healthy adult individuals were invited, among which 78 participants responded. We used International Physical Activity Questionnaire short form for the data collection. Researchers dispersed the online survey form throughout their designated social media users and collected data from online responses. Test-retest reliability, criterion validity, construct validity, and the concurrent validity was done by SPSS version 25. Ethical consideration was given by Bangladesh Psychometric Society. In the process of translation, we have done literature review, then we have decided the original English version of the questionnaire, then translated into Bengali, and then finally we done the back translation. And the end of the translation process, we have done the pilot testing of the Bengali version. In the validation process, for face validity, non-expert opinion from 10 people were taken. For content validity, 5 expert opinions were gathered, from which the CVR and CVI were calculated. For convergent validity, independent t-test was done among gender variables and total made. For divergent validity, independent t-test was done among education and total made. And for concurrent validity, Pearson correlation coefficient was measured between single item question, measuring physical activity and total made. The sample consisted of total 78 participants, and among the participants, 42.3% were male and 57.7% were female. For educational group, 80.8% reported graduate and above graduate level. The percentage of age between 22 to 28 years was highest, which is 50%. For occupational group, 46.2% were doctors. The scores of content validity index were computed on the basis of the simplicity, clarification, and relevancy of each item. All items successfully attained CVI values above 0.79. Overall CVI is 0.83, confirming the good content validity of the questionnaire. Although we found low CVR for 2 items, but we are not going to discard those items as overall CVI is good. Hypothesis testing was done to confirm the construct validity, that means convergent and divergent validity and concurrent validity. In hypothesis A, there is a difference between gender variable mean of 630 and 489 both in male and female relating to total male, which is not statistically significant. That means convergent validity was not proved among gender variable both in male and female. In hypothesis B, there is no difference between education group mean of 510 and 555 in below graduate, graduate and above graduate level relating to total made, which is not statistically significant. That means divergent validity was present among education groups below graduate, graduate and above graduate level. In hypothesis C, a statistically significant high correlation was found among IPAC short form Bengali version and a single item physical activity scale, confirming the concurrent validity. We found correlation coefficient 0.819 and p-value was less than 0.001, which indicate high correlation between the IPAC short form Bengali version and the single item physical activity scale. For reliability estimation, we have done the test-retest method and the interclass correlation coefficient respectively. The collected data show a questionable convex alpha of 0.511, confirming a somewhat stable reliability and repeatability of the questionnaire. This was due to the questionnaire was open-ended and we have to done the code recoding of these items. The interclass correlation coefficient was 0.438 among the participants. And lastly, as a part of the need assessment or intervention evaluation process, a valid and reliable tool must be used to evaluate physical activity in this population. The findings show that the self-administered IPEC short form has reliability, somewhat acceptable stability and validity indices except for the convergent validity. As a result, when a researcher wants to use a short form of physical activity questionnaire, this tool may be used in association with the other questionnaires. Thank you everyone for patient hearing. Thanks.
Thank you, Khandokar Fatima, for your presentation. Now the floor is open for question answer session and discussion. I would like to invite all to ask the questions to the specific presenters, and I will also read the questions which are in the chat box. So please, is there any question?
I have two questions. One question for Professor Nazrul Islam. So Professor Nazrul Islam has shown that the bivariate analysis, the gender, housewife, the p-value is 0.002. Does it mean the housewife has heavy susceptible for osteoporosis or not?
Thank you very much for the nice question and tricky one as well. The chi-square test not going to say any significance. So it says possible relation with the factors, and that is the information. Of course, this is we need to be very careful about mentioning this one. This slide I kept intentionally as because not to give emphasis on the result of chi-square test, rather than chi-square test we can do to find out who are the variable among of the variable list is going to give some information as a risk factor. With that, we have to do the logistic regression and to find out your odd ratio as well as the confidence interval. And that will tell some information whether it is related with the risk factor of a particular disease, especially for osteoporosis or not. Thank you.
I was expecting to hear this answer because the housewives, they are more susceptible for osteoporosis. That means the girls, the women, they are sitting here, the working girls, you are better position than the housewife. So I encourage that the women should go for work.
The thing is, hypertension, diabetic patient, they had multimorbidity. So this is a different group of patients. And patients with multimorbidity come up with other health needs and other treatment requirement. And this cost is always higher. So if you look, I think what Sanjida showed that the treatment cost for diabetes, treatment cost for private facility for patients who have having both diabetes and hypertension, multimorbidity, they also had a higher cost than the individual cost of the individual disease treatment for hypertension, diabetes. So this is a very good question. And there are three different cohorts, if I understand, Sanjita just said. So depending on what kind of data are coming from that cohort, that is giving their mean. I think you did the average cost, right, Sanjita? That was the average cost. So depending on the standard deviation, so this mean is probably different. It's not sort of sum of the two conditions. That's what I understood from her presentation. Thank you.
The question is how you measured the adherence. And next, how did you do the randomization for your study? How did you measure the adherence, and how did you do the randomization for your study, 3 groups?
It was very nice question. Actually, due to time limitation, I could not see lots of information. The first question, how I did the adherence, that I already showed, but could not explain the cutoff values of adherence. There was 7 self-management components. If there is recording version or if anybody wants, then I can share with you the slides. Actually, for all components, there were some cutoff values we considered, and with that, we made it adherence and non-adherence in these 2 components. And the second was how I did this randomization. Actually, we did this study amongst all the diabetic patients of Thakurgarh district. And actually, majority of our diabetic patients, they are registered in our country under under any diabetic association. So most of the diabetic patients, they are registered under Thakurgarh Diabetic Association, that is called Thakurgarh Shastro Seva Hospital. So from them, we collected the patient list. And with the patient list, we made the randomization amongst all the diabetic patients. Thank you.
I have 2 questions to presenter. Sanjida Binte Ali. So I'm not sure you showed that, is there any difference in the pattern of drug use between the private and public? You showed the pattern of drug use in the hypertensive and diabetic patients separately, but was there any difference between the private and public facilities?
Actually, we did not see the pattern of taking antihypertensive and diabetic drug between public or private. We actually only see the individually the patient participant cases.
Okay, I asked this question because there was a difference of
No.
treatment
Actually,
cost.
we didn't say.
I asked this question because there was a treatment cost difference between the private and private. So maybe there is a difference with the pattern of use of drugs because the cost of drug varies between different category or trade names or brand. So I asked this question. So this was, I think, necessary to know the pattern of drug used in 2 facilities because as you were measuring the cost.
No, we didn't see this. We didn't get this difference.
Okay, this will be a suggestion.
No.
This will be a suggestion, I think, from me.
No, we didn't find any difference.
Okay. Okay, thank you. So my next question to Khandokar Fatima. So I'm just confused that how is selected 100 healthy adults and why the number is 100? So can you just explain how did you select the 100 healthy adults for your questionnaire, physical activity questionnaire, cultural adaptation?
We have dispersed this question through online platform, and then we found the
whose online platform? Your known
all of
or
the researcher.
or your Facebook message or your known only?
Yeah, we were for 6 authors in this research, and we 6 authors dispersed our online form through our online media, and then we got response like and the other reactions. Then we sent to them the questions again, and at first we get 100 response, and then the feedback was 78.
How did you measure they are healthy on online basis? How did you measure that they are healthy?
This was the limitation of this study, because we first, when the Google form said that if the person is healthy, the question was there. Because this was a self-administered question. This is the limitation of this question, that we cannot see they are healthy or not.
Okay, it's okay. Thank you so much. If there is no questions more from the audience and from the online participants, is there any question?
Thank you very much. But I don't mind if she used convenient method to, go for 100 participants. The main problem with me is a cultural adaptation. I know that it's a validation of the tool. So I want to know if you used any cultural adaptability checking for that, because it's not always, authentic to just translate it and conveniently used for the next step. So did you had any opportunity to check for cultural adaptation of the tool? আপনি কি কালচারাল অ্যাডাপ্টেশন করার কোনো সুযোগ পেয়েছিলেন? মানে শুধু লিঙ্গুইস্টিক চেঞ্জ না, আমি যেটা বলছি একটা টুল ভ্যালিডেট করতে গেলে আমাদের বাংলা ট্রান্সলেশনের পাশাপাশি কিন্তু কালচারাল অ্যাডাপ্টেশনটাও করতে হয়। সেই সুযোগটা কি আপনি পেয়েছিলেন বা করার কোনো প্রচেষ্টা চালিয়েছিলেন কিনা?
আমি বাংলায় বলতেছি একটু সুবিধার জন্য। আমরা যখন আপনি যদি ভ্যালিডেশন প্রসেসটা দেখেন, প্রথমে ফেস ভ্যালিডিটি আমরা করেছি। সেখানে আমরা 10 জন হেলদি অ্যাডাল্টকে জিজ্ঞেস করেছি যে আপনি এই প্রশ্নটা দেখে যা বোঝাতে চাচ্ছি সেটাকে আপনি বুঝতে পেরেছেন কিনা। ফিজিক্যাল অ্যাক্টিভিটি বা শারীরিক পরিশ্রম সংক্রান্ত যে কথাগুলো আমরা ওখানে দিয়েছি সেটা আপনি বুঝতে পেরেছেন কিনা। তখন তারা বলেছে যে হ্যাঁ, এটা আমরা বুঝতে পেরেছি। তারপর আমরা 5 জন এক্সপার্টের কাছে পাঠিয়েছি এই প্রশ্নটা। তারা আমাদেরকে বলেছে যে হ্যাঁ, কালচারালি এইটা আমাদের দেশের জন্য ঠিক আছে। এটা হচ্ছে আমাদের কালচারাল অ্যাডাপ্টেশন। এই জন্যই আমরা বলেছি যে ট্রান্স কালচারাল অ্যাডাপ্টেশন, কারণ ফিজিক্যাল অ্যাক্টিভিটি আসলে দেশ টু মানে এক এক কান্ট্রি টু কান্ট্রি ভ্যারি করে। তো এটা যেহেতু ইংলিশ, তো ইংরেজিতে যে শারীরিক মানে পরিশ্রমের যে কাজগুলা সেটা বাংলাদেশে আসলে হয় না। সেই জন্য আমরা এই দুইটা প্রসেস প্রথমেই করে নিয়েছি যেন আমরা এই টুলটা মানে মানুষের জন্য একদম ভ্যালিড হিসেবে রিসার্চারদের জন্য দিতে পারি।
Excellent. তার মানে কালচারাল ভ্যালিডেশনটা করা হয়েছিল। Thank you so much. I have another question to Bilkis Appa. So it's very small. Have you had any chance to go for theory of change workshop before implementing the intervention for the trial? Any theory of change or any formative assessments?
Thank you, Tasdik. Discussion. That was very nice question. No, I didn't do that much workshop, but actually it was a long process. We have started this from 2009, and the same questionnaire, same procedure we used for Bangladesh University of Health Sciences. As you all know, I was over there, and we had a long intervention. After that, we actually conducted the similar concept to Thakurga. So we didn't do like that. Thank you
so much.
Okay, thank you. Fariyappa, okay. One last question, because we are running out of time.
Thank you for very interesting different presentations. I have a question who worked with the English medium school students. Madam, I have a question. I think, I do not know whether I missed. Did you have a chance to see the differences between male and female students? So, and what is your idea regarding that you have gave some nice recommendations. Even within the recommendation, do you think that if we talk about the household core or activities, is there any gender differentiation? Did you find anything in the literature? Thank you.
Thank you, ma'am, for your question. Actually, no, ma'am. When I administered my questionnaire, then there is no such point to find out that type of answer.
Okay, thank you all for your questions and a nice discussion. Now, I would like to request the chief guest of the session, Dr. Mahfuzur Rahman, Country Director, Pure Earth, Bangladesh, to please say something on this session.
You know the advantage of long discussion that allows us chief guests to make a short or brief speech. Welcome to the first NCD conference. I mean, why we are considering NCD conference in 2022? Because we decided, we analyzed that uncontrolled NCD is a threat to the SDG. SDG has been initiated in 2016 for 15 years goal. So after 7 years, the developing countries in Bangladesh, policymakers, they analyzed, they understood that the uncontrolled NCD is prevalent and uncontrolled NCD has a direct threat to the SDG. Why it is a threat to SDG? Because there is a 70% of deaths are due to non-communicable disease. So if you want to prevent that, so there will be a lot of investment, lot of awareness, lot of education. So that's why it is, I mean, especially the premature death. I mean, if you have a death at 70, it doesn't matter. But if you have a death at 30, 35 in a family, then it matters, because the death can cause the family in ultra poor or below the poverty line. I mean, I read in the economics this week that the COVID pandemic led the population or the global forum to invest 750 million to make the graduation from the ultra poor to poor. So if you have a real COVID, not Omicron or Delta, but real COVID and a non-communicable disease in a family, the family should definitely go from poor to ultra poor. So it has direct related to the SDG because we need a lot of education and because we need a lot of awareness program. And we have also a women inclusiveness because have seen that the females have a high prevalence of NCD. So we need to aware the women at the same time. We need to empower the women. So there are many legs of NCDs that is directly related with SDG. To control the NCD, we need to strengthen the health system capacity. We need to upload the health policy that the government can strengthen their capacity. As Dr. Alian Haidar said, the COBRA trial is extended to the healthcare facilities to provide the free drugs to treat the hypertension, to treat the diabetes, because there is very unknown. The diabetes and hypertension is a silent killer to the population. To control this, so if we have achieved the MDGs successfully, especially MDG 4 and 5, and we are aiming to achieve the SDG. So if you want to achieve the SDG, so we definitely need to address the NCD properly. So because there's many legs. Just to add on, I mean, recently you have seen that the lead pollution can affect 1/3 of the children in Bangladesh. There are 800 million people in the globe. They have a high blood lead level. So lead has a multifaceted like NCD. So it can directly cause the child intelligence. So child intelligence, it can go to the education, it go to the empowerment. So we also need to address the lead pollution in Bangladesh and elsewhere. Thank you very much.
Thank you very much, the honorable chief guest of this session. And I did not welcome you in the beginning, so I welcome you to the session and for your very wise deliberation. And my apology in advance for the chair and the chief guest of the next session. And thank you for bearing with us. I'll finish in just 2 minutes. Just to summarize very quickly that we have 5 presentations from very different areas. So we find that the situation in NCD surveillance in Nigeria is not different than Bangladesh, and it is a global issue, and we need to think forward how we can find solutions that is not only applicable for Bangladesh but globally. So Dr. Nozrul's report is a very alarming when it says the osteoporosis treatment, around 90% people are already on steroid. That means people are in a severity mode of a disease. So we need to do a lot of preventive measures for that. Ms. Sanjita actually presented a wonderful study because it shows for the first time that what is the cost that patient bear for hypertension, diabetes, or who has multimorbidity. I think these research should be, all this research should be published, and because the policymakers need to know this information for policy formulation. The wonderful study done by Dr. Bilkis Banu about looking at the technology versus traditional education, and it's good to know that smartphone use actually having better impact on adherence of the lifestyle behavior for diabetes among adult patients. That will be low cost, and probably coverage can be made high and accessible as well. And that Navira Aftabi actually looked at the very critical area of food habit of children and people. More than 40% of children are ordering food from online food caterers for more than 2 times. So this is quite alarming. And when we're going for class from home policy, we need to think what is the consequence of COVID on health. And finally, Dr. Khandakar Fatima, so you had done a nice adaptation of international physical activity, and this is a very important study, and I will highly encourage you to publish so that people in Bangladesh can use it. So this was a very vibrating session, and I thank the audience both in Zoom and in the hall, whose participation made it a vibrant one. And of course, my heartfelt congratulations to all the speakers and international speakers, Kingsley, who is sitting overseas. And of course, my heartfelt gratitude to the chair, chief guest, for being with us and having patience. So thank you very much. We look forward to the second session.